Hi everyone, greetings from IWDS. I'm Dr. Chandraskhekar, Chief Dermatologist, Cutis Academy of Cutaneous Sciences, Bangalore. I'll be speaking to you today on difficult to treat hair loss patient. All the OPDs of dermatology, probably if you ask me, it can have at least 20 to 30% of patients who come with hair loss. More so in dermatology clinics which cater more to the cosmetology services. They attract a lot of hair loss patients. And as dermatologists, we know how difficult it is to treat a hair loss. And much more, we need to identify what is difficult. When I say about difficult to treat hair loss, that means there are two things. One is difficult to treat hair disorder. The second one is difficult patient. When you look into the difficult hair disorders, there are a lot of hair disorders, we know that. But these are some of the hair disorders where you feel it difficult to treat. One is frontal fibrosing alopecia, higher grade of androgenetic alopecia, both men and women. When it comes to alopecia universalis such as totalis, scarring alopecias, diffuse alopecia areata, dissecting cellulitis of the scalp, and cicatricial alopecia. These are some of the hair disorders which you feel it as difficult hair disorders. And of course, we need to spend some time in diagnosing these cases and treat them. But today, I'm more interested to discuss with you difficult to treat hair loss patient. This patient walked into my clinic with hair loss. If you can, I don't know how many of you know about one personality called Akmahadevi, which is cited in Sharana Vachana of Karnataka Sharana history. She used to have this kind of hair covering entire body, both front and back, with the hair itself. She is a devotee of Shiva. This patient with typical hair of Akmahadevi comes to my clinic, walks into my clinic, and tells that she has hair loss. So where do you see the hair loss here? What do you do in this such case? You'd like to brush it off? No, you have such wonderful hair, you don't have hair loss? No, we are not supposed to do it. The patient has come with an objective of hair loss, and we need to acknowledge the perspective of the patient. She has hair loss, so we need to acknowledge and accept. What are the difficult patients? I thought of asking these questions to my fellow dermatologists in Cutis Academy, along with my fellowship students and registrars. They all come out with fantastic answers. So these are some of the answers they gave me. Stressed out patients, high expectation patients, any patient with low budget are not ready to spend, obviously, because hair peptides are so expensive. If they start minoxidil, probably they need to use minoxidil for the lifetime in case of androgenetic alopecia. So definitely budget and not ready to spend is one of the factors which puts you into a difficult scenario. Grade 6-7 of Norvit or Ludwig grade 3 over 50 years of age. Patient who is stingy. And always these patients worry about the cost of the treatment rather than the real treatment. What would it cost? How much would it cost? So these are the patients which you feel difficult. Patients who indulges in chemical treatment for hair or hair spa repeatedly because they get hair damage, shaft damage repeatedly. Foreign returned patients, this is one category where they come to motherland and they see mother after 3 to 5 years, and they start digging and eating your head with so many questions, with so many ideas which they have learned there. They remember they don't get an appointment of a dermatologist in their working country, but when they come here in India, they act too smart in them. They are difficult patients. Difficult to convince patients. However, you want to convince them that you have such a hair loss, 30 to 40 hair, what you are losing is normal. Don't believe. Impossible to convince. Of course, VIP patients, each and every one of us have experience with VIP patients. They don't know what you prescribe, they don't listen to you, they don't really acknowledge carefully. They act too smart, these VIP patients. Non-compliance is a very, very major issue in case of patients. I'll be dealing with non-compliance in detail when I go further in my talk. Google Babas, too much of Googling. Of course, if you don't brush them, Google is one which has got a double-edged weapon. See, nowadays, even we want to buy something, we want to go somewhere, we want to experience something, we always Google. So don't take it as negatively these patients are Google Babas. You need to acknowledge and tell them exactly what is the exact information they have to get from Google. That is what is required from Google. Then unmotivated patient brought by spouse, parent or a friend. Son is not interested in taking treatment, but the mother wants because the marriage time is coming up. Then the spouse wants her husband to look young, but he is not motivated, and you don't really see him that he will do treatment what is it. Not ready to change their lifestyle. There are some people, however it is, you say that see your hair loss is depending on your lifestyle because you have an androgenic stimulation because of the overweight. However, you want to tell them to change their lifestyle, they will never do. Refuse to understand and acknowledge the problem. There are some people, however you explain, they don't understand, they don't acknowledge the problem what they have. Patient not wanting minoxidil or finasteride as treatment options. They must have read about them. Even trivial side effects horrifies them and they don't obey you to take it. There is one category of patients which I have seen. They are never satisfied in their life with anything. Whatever it is. There's nothing called satisfaction in their mind. Whether it is their routine, whether it is their office, home, whatever it is you take, they're not satisfied. Such patients are difficult to tackle. Then, of course, the major thing what I'm going to discuss today is the patients with psychopathologic disorders. When you look into all these categories of patients, probably you see major 5 different patients which you feel it as difficult when it comes to consultation and treatment. Angry and defensive, resistant patients. They are defensive, angry, they don't listen to you. Manipulative patients. You know that this patient has to use 3 bottles of minoxidil over a period of 3 months. When you ask them, they would say, I've used 6 bottles. Or you say that, no, you'll have to use 1 bottle per month, that is the dosage. Then they immediately correct, no, I have used only 3 bottles. So they try to manipulate in all the matters, in all the ways. So these are patients that are difficult. Traumatizing patients, the hair loss is very trivial. Maybe they lose about 20 to 30 hair, but they feel that they are losing entire hair. These are traumatizing patients. Grieving patients, they grieve for everything. They'll start telling that my mother-in-law is like this, my father-in-law is like this, something like that. Home factors, home matters get into your clinic, and these are grieving patients. They grieve for everything. Frequent flyers, of course, it's very, very common in dermatology practice that the patients, because if you take any dermatology disease, including a fungal infection now, it takes its own sweet time. The patients are in a hurry. This is the era of fast food, fast flyers. So they expect magic results. That will not happen in any clinic. So they become frequent flyers. These are difficult patients to tackle. Remember one thing, whatever it is, across your consultation table, impossible people exist. You should acknowledge the fact they exist. You'll have to encounter them. You can't avoid them. You can't fix them. You can't make them to like you. So you want your patient to like you. You want your patient to establish a relationship with you, but you can't. Some patients, you can't punish them, and basically they may not want your help. They must have come just to inquire about you. They must have read or they must have heard about you. and they just want to experiment. In fact, they were not wanting to help at all. Apart from this, there are difficulties as a dermatologist we face when we encounter hair loss. Alopecia areata misdiagnosis as AGA. Maybe after 3 or 4 months of treatment, you may come to a understanding that this could be alopecia areata. Diffuse unpatterned hair loss in women especially. Alopecia areata along with androgenetic alopecia. So you'll have to think of a multifactorial etiology for the hair loss what you're attacking. Then the allergy to the formulation itself. Maybe they are allergic to the alcohol, they are allergic to the propylene glycol, they are allergic to the other ingredients of preparations of peptides. Basically, they may become allergic to minoxidil itself. Other hair disorders like short anagen syndrome, alopecia totalis, universalis. These are the hair disorders you really face a difficulty as a dermatologist. And of course, the phobia, especially a finasteride phobia, is very, very difficult to tackle. One of the major things a hair loss patient exhibits to you is emotional. They feel that they are ugly. The first thing they feel that they are ugly. There are two types of emotional effects which come in a hair loss. Number one, beauty and outlook emotions. Number two, the social and personality emotions. If you consider all the dermatological diseases which have got emotional overtones, I think hair loss would category say it could become number one in that. When it comes to beauty and outlook emotions, they feel that it's at the end of youth. They feel that inability to style the hair. They are dissatisfied with their body image. They have low self-esteem. Of course, they feel that they have lost their personal attractiveness and they are not looking attractive to others. They fear them. In social and personality emotions, they feel embarrassment, loss of confidence, shyness, social teasing and humiliation, feeling of depression and introversion. They become envy, they become jealous, they get into work-related problems, and they always have negative social life. That means to say that hair loss is highly emotional. They become too emotional. That is where you need to strike a balance between your consultation, your diagnosis, your treatment. There are some desperate acts by the patients to overshadow. Probably they start wearing hats and caps. They start exercising to improve their physique. So the attraction of people who are looking at them would go to a physique rather than the scalp. They start growing beard, mustache, so the attraction goes. And they feel that bald men are intelligent, they are super, something. Then, especially female population would start dressing nicer. So all these are the point I want to say that such an emotional effect of hair loss is making our patients or people to follow these overshadowing practices. So you should recognize the intensity of the problem. It is said it's easier to write a prescription rather than to come to an understanding of the patient. Yes. Understanding the patient is such a tough, but the prescription can be given easily. So this is what it means. So if you look at successful treatment of hair loss, difficult hair loss, there are two categories. One is clinical, second one is psychological. At a clinical level, probably you'll have to take a detailed history, examine the patient, then get the chronology of events, especially if patient is suffering from chronic repetitive telogen effluvium, where patient gets a telogen effluvium 6 to 8 times, then ultimately gets into a female pattern hair loss. So you need a history. You need to examine the scalp if there is any obvious pathological evidence. Then think of a pattern of hair loss, whether it is alopecia areata, telogen effluvium, or androgenetic alopecia. Of course, do a clinical test of full test to see whether this patient truly belongs to a telogen effluvium, truly belongs to FPHL or AGA, then do a trichoscopy is one of the best instrument we have in our hand nowadays as dermatologists. Dermoscopy. So trichoscopy will give you a lot of clues about the primary hair disorder. Plus, it also prevents a biopsy. It also tells where the biopsy is to be taken if it is taken. That is that, and also it also helps in prognosis of the treatment of hair. There are screening lab tests probably if it is a hormonal hair loss, especially for females. If there is a metabolic disease associated hair loss, or the hair loss itself can have a metabolic disorder like insulin resistance, etc. So you can do those tests. And ultimately, if your clinical examination, dermoscopic examination is not able to pinpoint a diagnosis, probably you can do a scalp biopsy. For successful treatment of hair loss, the primary thing is a prerequisite diagnosis. What the patient is suffering from. But remain open-minded because there can be a possibility of multitude of considerations. The patient can have an alopecia areata with an AGA, patient have a trichotillomania along with AGA. So multiple causes can be there. So you need to be aware of it. Pathophysiological understanding of the disease is very, very crucial. You need to think about cause, its relation to the treatment. Open mind, always have open mind, especially dermatology is full of combined treatment. You look into your practice history. For any dermatological condition, probably you will have to have a combined therapy. So that's exactly true with hair loss patients. Probably you will have to think of good medical practice. Good medical practice is something which has come out with your experience in the background of evidence-based medicine. A particular condition has got such an evidence as a treatment, but it also requires you to blend your clinical experience, blend your therapeutic experience, along with the good evidence-based medicine. That is called good medical practice. That is very, very optimal, very, very requirement for treating hair loss. Always, because these hair loss conditions are going to take a very, very long time. For example, an AGA patient will be a permanent patient for the life, as long as he wants hair. So that means you should have a good follow and you should have good digital photographs to rejoice the improvement along with your patient in the journey. That's what you should follow. On a psychological level, if you look at this photograph, you have one side clinical, one side psychological. But the major chunk of the practice, a perfect practice of hair loss, is in the middle where you blend clinical and psychological. Both has to be blended together to give a good treatment to a difficult hair loss patient. What are the general measures? Generally, you take it's not only applicable for uh, patients of hair loss, but generally when the difficult patient interactions come, probably these are the general measures one should take. Please test your patient. We know our attendants. When the attendant comes, don't brush them off. Agree to disagree. Sometimes you need to do this. You need to agree that with your patient, you need to agree, you need to disagree with your patient. Catch the mistakes made by the patient. Very important because you need to have this patient for a very long time. Try to catch. They must not have applied the medicine properly. They must not have taken the medicines in the way advised. You try to catch them so that you can hold them for a long time. Using phrases like, I know you are feeling when the patient is worried too much, you should acknowledge this. I know that you are angry, you are upset with the treatment failure, but please do not worry, we are there with you. That is the language you should speak. Estimate the cry for help. The patient has come with a lot of emotional problem, emotional overdose. So we need to recognize it. Partner this patient with your journey. So the journey of hair loss treatment is very, very long. Whether you take an alopecia areata or any product, even a simple telogen effluvium, the journey would last for about 1 to 1.5 years. You need to accomplish that. create an extra time slot appointment for a different difficult patient. So when you consider that this particular patient who is walking into your chamber is a difficult patient, probably you need to carve out some extra time, extra appointment. Remember, do what they want. Sometimes you know that your treatment is working well or is not working well. You need to do what they want. Give timeline. Suppose the patient comes take a treatment today, within 1 week, don't expect results, and you can't assure this. So you need to have a timeline for kilogen approval, for androgenetic alopecia like that. If patients are lying, don't say that they are lying. You know that the patient who is sitting in front of you is lying, but don't say that. Accept it, and you know that the patient is lying, but put it in a different language to say them what they're telling is wrong. What are the key concerns of these patients? Key concerns are you need to address them. Number one, address directly and specifically what is the problem. Acknowledge the patient's perspective. Explore patient's expectations. Very, very important. You know to what is their expectation. Educate about basics of the hair cycle. Because once you love that treatment, once you know that it's going to work after 3 months, why is it working after 3 months? What is the hair cycle? And remember, patience is the key. Not only from your side, even from the patient's. Once you read, probably if you look into a basic psychological disorder, probably they may have a depressed mood, they can have an anxiety or disturbance of conduct, traumatic and sexual dysfunction can be there, feelings of guilt and obsession. So when we're talking to the patient regarding these concerns, you should be able to judge, you should be able to pick up what could be the underlying psychological disorder this patient could have. Most of the time it is adjustment disorder. So the best way to treat the adjustment disorder related to hair loss is to effectively treat the underlying hair disorder. Of course, we know that if the underlying hair disorder is diagnosed precisely and the treatment is available, we can do that. But if it is not, then we'll have to hold your patient. So only a minority of patients suffer from imaginary hair loss. If you take maybe 100 patients of hair loss, probably in my experience for a period of so many years, maybe around 18 to 20 years, the imaginary hair loss patients, only a few, not many. So that you should keep it in mind. Patients with imaginary hair loss have varied underlying mental disorders. Most probably they have overvalued ideas or they have the delusional disorder. So you need to aim at making a specific psychopathologic diagnosis in this. When I come to a treatment in the management schedule, I'll tell you what you like to do for it. See, there is a lot of research which has gone to define what is difficult patient. The one literature said 1 in out of every 6 dermatological consultations are difficult. But in experience, when it comes to hair loss, I would feel, because I see a lot of hair loss patients, more than 100 per day, I would say that 1 in every 4 patient would be a difficult hair loss patient. So, when it takes to difficult hair loss patient, the literature also warns that do not consider the patient as the only cause for this. Do not put the blame entirely on the patient. No. It suggests rather the clinician-patient relationship constitutes the proper focus for understanding and managing difficult patient. So, the relationship what you establish with the patient should also be taken into consideration when you define a difficult patient. Simple. What is a difficult patient? If you cannot establish a therapeutic relationship, I'll repeat, if you cannot establish a therapeutic relationship with the patient, that patient becomes a difficult. How is it possible? How can you establish a therapeutic relationship? The patient is basically communicating. If the communication skills are good, it is possible. Then secondly, these kind of interactions won't come from a negative patient experience with your own clients. I'll take an example. If a patient of androgenetic alopecia is gone, to a senior dermatologist. They say nothing can be done. This is your heredity. It has come to your father, mother, parents, grandparents. Nothing is available. You will have to suffer. So many people are born in the world. Why do you worry about borders? Please go, don't do anything. It is not going to have anything. If these kind of negative experiences are there with our own colleagues, then it becomes a problem. So probably we should consider that. So it requires a detailed history. Others are specific psychopathological disorders. Most probably it's adjustment disorders and imaginary hair loss, something like that. The most important thing in patient communication is here what is not being said. I'll repeat. You should hear what is not being said from your patient. It is something like reading between the lines. To understand this, probably you should have a very focused eyes and you should observe the body language of the patient. So by talking, you also think about the body language, observe the body language of the patient, then probably you will be able to hear what is not being said from the patient. That means you will be able to pick up that psychopathological disorder in the patient. Probably the communication includes you have to listen to your patient, understand your patient, involve the patient on diagnostic procedure, diagnosis, therapeutic considerations, what may be expected from the treatment, and how are the prognosis of the disease, what is he suffering or she is suffering. You need to convince your patient. You need to give a hope to your patient. Now nothing to worry, the hair loss is going to come down at time. Be cautious, don't promise. Promise is different, hope is different. Leading the patient to take personal responsibility of his treatment. Jointly rejoicing over therapeutic progress if over a period of time, when they comes for follow-up, you are seeing the improvement. Probably you need to rejoice that. So both of you should be happy about it. Communication has got a significant impact on patient's well-being. If you think patient is satisfied and walking out of your clinic, that means your communication levels were good. They were satisfied. A smiling patient walking out of your clinic would tell the communication skills of what you have is good. Failed communication is the most important reason for patient dissatisfaction. So you need to have that good communication skills. Communication skills is not a talent. Of course, some people are very good at communication by birth, but majority of the people, you can acquire communication through training, through experience. The experience can be given by your own patients. Probably over a period of time of your consultation, your career, you will pick up these communications. There are two things which probably push you to develop a good communication skill. One is, if you are interested in the problem of hair loss at clinical level, don't consider the hair loss is there, you can't do it. No, hair loss psychology is a big science and you should have an interest in it. Number two, you should also have interest in the patient. So interest in the patient, interest in the problem of hair loss will allow you to develop much more better communication skills. During communication, these are the things you should avoid. One is precipitance and restlessness. You should not become restless. When you walk into your clinic at 9 o'clock, the same tempo, same enthusiasm should be there when you leave your clinic by 8 o'clock in the evening. Because the patient who is walking in at 9 o'clock will also feel that you are fresh, and the patient who is walking in at 8 o'clock in the night will also expect you to be fresh. Expect you to think in the same way, expect you to diagnose with the same precision, and expect you to give the same line of treatment even at 8 o'clock after you have not seen about over 100 people. That is a patient expectation. And don't have a personal dominant behavior. You need to partner your patient with the treatment, because these are the patients who are going to there for a very long time. And stereotype prejudice, especially the hair loss patients, when you look them, they come in herd. This patient has taken, her friends will come. This family has taken treatment, another family will come. So you should not have the same prototype of treatments. You should be probably intelligent enough to think what is being given is not repeated, at least the same practice. Believe, believe, believe. Believe in yourself, in your patient, and in what you do. Believe in the power of positive thinking, power of images, what you have stored about here, and the power of belief. So this is all about belief. If you have such a belief in your technology, in your storage, in your images, what you have captured, then probably it becomes very easy to communicate with the patient. This is what exactly happened when I started my career. I started using uh, topical finasteride in 2011, and we produced one evidence in 2014. But the real evidence came at 2018. That means to say I believed that this particular treatment is going to work in our patient. So that got proved over after a period of 7 to 8 years. Similarly, when I started using topical of minoxidil, when the same story, then the evidence started pouring in from 2017 onwards. Similarly, with hair peptides, I started in 2012. Then in 2018, this literature, when I wrote recent advances in psychology, I could able to see a n number of references for peptides in hair loss. Similarly, the PRP, we started in 2014-15, and large evidence which started pouring in for PRP in 2018. So what I mean to say, you should think all the possible ways to treat your hair pain. So as I said in the beginning, evidence is there on one side. There's a basic literature, basic science on a particular treatment. You need to think of your experience in treating and combine these two. Probably you would become the first person to produce an evidence on what you're treating. That's what I mean. It is said that educated physician, there are two types of physician. One is a physician who treats, and another is educated physician who understands the mind of the patient. So if you can combine your clinical skills along with understanding of the mind of the patient, probably you will become a good trichologist. That's what I mean to say. These are some of the psychopathological disorders. Probably I will not going to touch enough on that, much on this. But most important disorders are four. One is called adjustment disorder, hypochondriacal disorder. Then you have paranoid disorders, that is personality disorder. Then you have a nocebo effect. Number one, adjustment disorders. The most commonest disorders found in hair loss patients is adjustment. It comes from stressful event of hair losses. So they have a depressed mind, anxiety, mixed anxiety, depression, etc. The intensity of the distress the patient feels should be a part of clinician's formula in deciding how aggressively you are going to treat them. So you should be able to recognize that intensity. That's what I said on the focused eye on the observing the behavior of the patient when the patient is sitting in. This will give you a clue. In hypochondriac disorder, actually there is no real illness. It's an imaginative. So the most commonest condition among this could be imaginary hair loss, or we call it a psychogenic pseudoeffluvium. Whatever the investigation, whatever the reassurance you give, whatever the basic care cycle we explain, however you want to take this patient into confidence, the patient is not going to listen to you, not going to accept. So this is hypochondriac disorder. Has no real illness. So it's not psychogenic pseudoeffluvium. What is the complaint of these patients? It is disproportionate to the extent of the recognizable hair loss. You see about 30 or 20 strands of hair, they said that I lose around 150, 200, 300 and a bunch of hair. This is because probably they would frighten, they would go bald, or they must have seen their dad or mom or somebody or a friend becoming bald. Probably that must have triggered this. It only makes up a minority of the patients, but significant it is. You need to address these patients. These patients could have two ends. One is the neurotic end of the spectrum, or probably overvalued ideas. Majority of them can have a delusional disorder, or they can have a depressive disorder, body dominant BDD, that is body dysmorphic disorder. Of course, here the differential diagnosis becomes challenging. You have to understand these patients. Probably in very extreme cases, probably you would need help of your psychiatric friend here. The third one is body dysmorphic disorder. It's preoccupied with a non-existing or minimal cosmetic defect and persistently seeks medical attention to correct. We know about body dysmorphic disorder. It's very relevant in cosmetic dermatology, in aesthetic dermatology, and also with hair loss. So they have conflicting beliefs. Their actual is different, their desired self is different. So there is a conflict with their personality. This is body dysmorphic disorder. There are two complexes here explained in literature. One is Thurston's complex and the Dorian. But forget about it. I would like to tell about Indian mythological figure, Yayati. This is, according to me, it's called Yayati syndrome for India. You must be knowing Yayati's story. Or if you don't know, please read about it. It's quite interesting. So here, the patients wish to remain forever young and seek lifestyle drugs, like including hair growth promoting agents and surgery to deter the natural aging process. It is named as Dorian Gray syndrome in Urdu's Oscar Wilde novel, but it is the same exact thing what Ayati personality depicts in Indian mythology. Then you have personality disorder. Very important. A lot of people who come with, especially the hair loss patients, phobic patients, they have this lot of personality disorder. The most important thing what I would like to advise, don't become judgmental or scolding with this patient. Once you start judgmental and scolding your patient, it cuts off your therapeutic relationship. It closes your communication. There ends the matter. So please do not be judgmental. Do not be scolding with this kind of patients. These kind of patients, it becomes a vent, your clinic becomes a vent for them to, for a caring physician like you, when you are talking so good, it becomes a vent to express their emotion, express their feelings. That's why I said, told in the beginning and the middle, if you feel these kind of patients are there, probably you need to carve out an extra time for them, an extra consultation time for them to give your ears to their problem. Accordingly, probably because you're putting your time there and you're putting your efforts there, you can have a different slot of consulting fees for them. So this is important. Out of 100 patients who come to you, probably 10 or 15 may need this for a period of time. That you should recognize. Then once you analyze the psychological disorder or the clinically make a diagnosis, then you start that response to treatment. Then the question comes in the follow-up, is it working? I have recognized 4 types of answers. Number 1, doctor, it is working, thank you. Very simple, straightforward, you are happy, the patient is happy. Second category, doctor, I don't know, you have to tell me. They cannot judge themselves, they want to, somebody else should take a decision on their behalf. This is the mentality of these patients. So here you need to check dermoscopically, photographically, global photographs, check whether the patient is improving or not. If it's an improvement, you can tell them it is an improvement. If it is not improvement, you tell them that you need an extra treatment, they obey. These kind of patients are not decision makers. Number 3, doctor, it's fantastic. I can't believe. Some patients will come, they say, no, it's fantastic. Although you feel that there is a subtle improvement, their outburst is, oh, fantastic, thank you so much. These are the patients who become two-edged weapons. These are something like a knife. I think if they can promote you, they can also dispromote. So this is something called a placebo effect. You know that you are given something placebo-like thing and the patient is happy. And the 4th category of patients, doctor, what did you give? It's too bad after your treatment. I'll tell you, I have a lot of experience with this kind of. This is called nocebo effect. All of us know it. They come and tell you, nothing has worked. It has gone worse. I did not expect this from you. Your medicines are not working. Instead, they are causing more problems. I have started itching, I have started burning. All these kind of. These are personalities called nocebo personalities, nocebo effect. This is clearly depicted in this. The influence of the prescribing physician should be kept in mind in nocebo. Since inspiring confidence versus skepticism in the patient, and fear clearly impacts the outcome of the treatment. They are skeptical. These patients, I, I don't know how to explain and how to put it across, but these kind of patients do exist, and I see them routinely in my practice. They have these specific psychopathological disorders, like anxious personality disorder, negativistic personality. They look everything negative. So they can't see anything positive in any fact of life. So these are the personalities. Histrionic personality, paranoid personality. So these are the patients who come with a nocebo effect. If you feel that what you are given diagnosis is perfect, what you are given treatment is perfect, and you expect the patient to do well, and in fact, objectively the patient is doing well with the evidence, but still when they say, please consider, be careful about this patient. Very, very careful about it. So probably it is more common among women. How do you manage psychopathological disorders? So what are the effective methods? Probably wherever it is possible, make a precise diagnosis and initiate effective treatment. Be a psychologist and psychiatrist by yourself. In 20 years of my experience, at least 8 out of 10 patients whom I have referred to psychiatric help have come back to me telling that probably I'm better than them. So probably you should become like that. Not only as a psychologist, as a dermatologist also. Learn counseling skills. Know about basic and common psychotropic drugs. Don't hesitate to use them. I use a lot of toxicant, a lot of metazepam in patients. So we should know how to use them, side effects, profile, interactions, all these things we should know. In case of extremely rare cases where you feel that this is incorrigible, not able to handle, then what you take a psychiatrist step. Most importantly is ensure the patient compliance. What is patient compliance? Most frequent reasons for non-compliance. They deny the problem, lack of comprehension and treatment effects, occurrence of fear of side effects, cost of treatment, complexity of treatment regimen, poor previous experience with the physicians, poor communication, lack of trust, neglect, and forgetfulness. These are the reasons for non-compliance. You should address these reasons for non-compliance. The treatment success relies on patient compliance. Very, very crucial and important with all respect of medicine, with all aspects, branches of medicine, is the compliance of the patient. It depends on comprehension of treatment benefit, the confidence the physician gives, and a motivation the physician gives. A positive physician-patient relationship and regular follow-up visits are the most important aspects, or the most important factors which determine compliance. The therapeutic relationship you establish along with the follow-up of the patient is one of the best indicators for a good compliance. Only recommended treatments that are effective in the given circumstances. I'll come to that. I'll give an example. So there are two types of compliance. One is the short term, one is the long term. The overall goal of any treatment is to give a short-term compliance for the first 3 months, then long-term for the next 6 months. The short-term compliance issues addressed by the physician within the first 3 months. That is building the patient's confidence in the diagnosis and treatment plan, detecting the problems related to the prescribed treatment regimen, and drug tolerance. In 3 months, you should address these. Establish a therapeutic relationship with the patient. Look at what you have prescribed, their side effects, their concern, their interaction. All these they form the first short-term compliance. For example, a patient of probably grade 3 Ludwig pattern of female pattern hair loss comes to you. Immediately there is some family function, something is happening. So you cannot have a long-term treatment plan to satisfy her in the short term. You need to address her probably with the hairpiece or with the hair powder. Something like that for a camouflaging technique. That's the best way to deal with it. So that is what is meant by a short-term complaint. In a long-term complaint for the same patient, you can have a topical minoxidil, oral antiandrogens if it is possible. Probably in case if there is enough good donor area, hair transplantation. This is an example of short-term and long-term complaint. So you need to plan this. As I said, long-term complaints addressed at 6 to 12 months of follow-up. Probably you'll have to think of your efficacy of your treatment, sustainability of your treatment, long-term toxicities of your treatment, and treatment costs. All these should be come in a single basket, analyze, think, make your patient as your partner in decision making of long-term complaints. How do you improve complaints of your patient? Try to prescribe minimum number of different medications. Combine them. Probably when you ask me that treatment history of androgenic alopecia dating back to 2-3 decades or 2 decades is simply minoxidil, then probably there is evidence gets creeped into minoxidil finasteride, then next finasteride plus peptides. So if you combine drugs, it makes patients life easy. Simplifying the dosage regimen. Few doses, takes a few doses for the treatment. Make it simple. So this is the way of thinking when you are treating some disorder or some disease which is going to take a very long time. Select your medicines which have got a low side effects or low risks. These are the methods to improve compliance. You discuss possible side effects, whether it is important to continue medication. For example, if there is a little bit of irritation with minoxidil, tell the patient initially it happens and over a period of 3 weeks it goes off. Or prescribe a mild steroid lotion to combat the probably it could be an irritant reaction. Watch for a regular allergic reaction later on. So this is how you manage. Advice, minimizing the coping with side effects, how they can do it. Initially the hair loss would increase with minoxidil, you should be able to tell your patient. Regular follow-up for reassurance is indicated in these patients. Developing trust to so patients don't fear embarrassment or anger if unable to take a particular drug. Probably if prescribe one thing patient is not able to take, please don't scold them, don't become angry on them. You always try to find out an alternative. In summary, over a period of time, what I discussed was what are the patient difficult interactions you have, what are difficult patients, what are the psychopathological disorders who are there with these patients, how exactly you are able to recognize them, how are you going to address them. So in summary, only few dermatological problems carry so much of emotional overtones as hair loss. For a successful encounter at an office visit, address key concerns of the patient. The most frequent mental problem with these hair loss disorder patients who form a little chunk of your practice is adjustment disorders. So you need to address that. Only a minority of these patients will have imaginary hair loss. Try to understand the underlying mental disorder there and try to address it. The most frequent cause for difficult patients is probably the negative experience they have or they had with your colleagues. Others, when you are not able to recognize, they become psychopathological disorders. You need to recognize them. Take care not to be judgmental or scolding because this may rapidly close down the relationship between you and the patient. A difficult patient is one where you are not able to establish a therapeutic relationship. Probably that is because of these attitude of ours. So we need to address them. The influence of the prescribing physician should be kept in mind since inspiring confidence versus skepticism and fear clearly impact the outcome of it. So overall, you need to recognize the difficult patient. You need to address the difficult patient. You need to have plans to encounter these patients. And you need to, at the end of the day, you need to establish a therapeutic relationship with these patients for a better outcome. When I see this difficult hair loss patient, probably I would acknowledge my fellow doctors, colleagues, technicians, and tutors. More than that, Thousands of hair loss patients whom I have treated at Kutis for the past 2 decades have taught me so much, have taught me to overcome the difficult patient in majority of the times. So I hope probably this lecture of mine would help you in that regard, in that direction. Thank you very much.